of the task force. The membership of the task force, while we thought, a dozen or so folk would be great, and we'd come up with a report in a month or so, in order for us to be at least somewhat fairly inclusive, to go as deep as we needed to, ended up being some 52 individuals. And if you know some of the names, you can see that they are staff at large, they are faculty, they are students, residents, they're Mount Sinai trustees, some of the most senior leadership, hospital presidents, and so on. And this work has been supported in large part operationally by our Office for Diversity and Inclusion key staff that you can see there, but also others, including Ben from operations, Mark, and a few others from communications, and so on. And I have to acknowledge Leona Hess, who was truly, who has been the architect for the work, the process, and helping us to identify the necessary consulting group, FSG, to work with us as we begin the process of implementation. And so back in around July of 2020, we came together for the first time, and we used collective impact as our process for both framing, understanding, and advancing the work of the task force. And over the course of 6 months or so, we developed consensus for what ultimately became the proposed strategies and measurement and other processes to move us forward. You can imagine that even if we had 12 people agreeing, first of all, having the conversation was not easy, and then agreeing, gaining some consensus on both what to do and how was very interesting, but challenging, but also important to do. We did at times have to take a pause, and that's why what might have been a 4 to 6 week process ended up being much longer, but it was clearly a process where just about everybody who was involved agreed. There was a lot of learning, a lot of coming together for us and for our community. Ultimately, the roadmap was finalized around December of 2020. And then with internal sign-off and agreements, it was published in early 2021. Okay. So the roadmap, which is now easily available on our website, includes a bunch of things. One, a set of recommendations, including strategies and interventions for addressing the issues that we looked at as challenges that ultimately will make Mount Sinai as a health system an anti-racist health system, right? So that is different from addressing diversity or diversity inclusion or equity alone. That's a tall order, and we recognize that, but that is really what this roadmap aims to do. The roadmap, in addition, presents guiding principles as well as a process for moving us forward. So the North Stars become an anti-racist institution, right? In order to do that requires much more than managing a bunch of projects and activities, right? And that is important to appreciate as we go deep and broad. Right? Here are the strategies clustered together in ways that hopefully can make sense to folk, including us today. And I'll go through these very quickly and come back, particularly for those, have a conversation around those that are more relevant to you all as a department of critical care. Strategy one, you can't address what you can't measure, right? And so developing a scorecard that helps inform the process, helps us to appreciate progress along the way, and to hold ourselves accountable. Critical. Okay? healthcare delivery. Probably the toughest, and by the way, the actual language for the strategies are much longer. These are just summaries that allow us, to sort of appreciate the content behind them. But probably, one of the most difficult of all the strategies relates to what has become more and more apparent, particularly this past year and a half, regarding the unevenness in which care manifests itself across systems like ours, but including ours. Integration and unification, while there's a lot of work going on, including in this department, but how do you, unify, how do you partner, how do you integrate in order to have a larger impact? So integration and unification with a particular purpose. But just like measurement, good work can't be done and even more importantly, sustained without an investment. This strategy 6 and 7 allow us to look internally, ask the tough questions, and then help to define what it will take, what kind of investment will be necessary to get the good work done and sustain it over time. In addition, it allows us an opportunity also to look inward and a little bit beyond the Mount Sinai base, but at the communities around us. And this begs the question of how do we invest in our local communities, particularly for MWBEs, with MWBEs in mind, so that we have healthier communities, more connected communities that Mount Sinai can help to resource up and help advance a little bit further. Organization, institutional, well, some of the more obvious work that still needs to be done. And while in many departments we've done better, as it relates especially to leadership diversity, there's a lot of work still needs to be done. And that then, of course, relates to the need to have even more and more mentorship opportunities for folk who we invest resources and time in to advance along the way. And then finally, strategies 10 and 11 aim to look at how we engage each other, particularly leadership, so that this is a community a learning community that grows in the right direction with anti-racism in mind. And clearly that requires more resources, more dedicated resources, so that we become both smarter and more learned in the anti-racism space. So those are the 11 strategies clustered in a way that hopefully can make sense to most who read them. The language to the strategies, the absolute language is online on our website. And I encourage you all to take a look at them. And as well as the dozens of interventions that help to advance the strategies. In addition to recommendations for moving forward to aim towards our North Star, the roadmap presents a process for moving forward and an organizational structure. The process that we used to engage and do the work of the task force was collective impact. And I don't have time to go into collective impact at this time, but it allows one to go deep and with intent and bringing folk together from disparate points and points of views to advance work collectively, particularly as it relates to social change in addition to others. It is different from just applying project management, but takes into account managing people, change management in addition to projects, and allowing to go fairly deep. It is a timely process, an important process, and as I pointed to before, becoming an anti-racist institution is different than addressing diversity or diversity and inclusion or aiming to address equity. Right? Those, in my mind, are higher, more towards the top of the surface, but to really have the kind of sustainable, enduring change that we have in mind, it does require going much deeper, much more broadly, much more together, and over a longer period of time. That's the process. Organizationally, there is an existing Executive Diversity Leadership Board that Ken Davis, our CEO, chairs. That board will become the the highest organizationally positioned structure to oversee and hold us all accountable for getting the work done over time. Many of the circles that you see surrounding the Executive Diversity Leadership Board are groups, some councils, you'll see, for example, that already exist, for which we will draw from. And many of the leads for those councils and groups already sit on the Executive Diversity Leadership Board. Where that doesn't happen, student council, for example, we will figure that out to ensure that there's the necessary participation in the process, the review is of student voices, among others, exists. Right? The Office for Diversity and Inclusion is already carrying the bulk of the backbone support, and in addition to guiding, we will be mobilizing the resources to support getting the work done. So that does mean expansion of staff and resources at ODI. But it's not only ODI, and as I referenced a few minutes ago, FSG, a consulting group that is really the best in this space, maybe the only legitimate player in the collective impact space in addressing issues like this, has been brought on to support us getting the work done, but particularly in what will be necessary for shared measurement. What that looks like for us, how the work gets done, how we benchmark success, how we drive and advance success. On the right side here, aims to illustrate that for each of the 11 strategies, there was a strategy lead. Those individuals are as high as we can get in our executive leadership across the system, that will be the ones chiefly responsible, accountable for the strategies, owning the strategies and bringing together the working groups to think through, line up measures, among other things, and of course, getting the work done. So for strategy 2, you may recall that relates to care delivery. Jeremy Bowl, who is the Chief Clinical Officer for the system, the president for Mount Sinai BI, is the lead for strategy 2. Okay, just to give you an idea of what that's beginning to look like as we begin to operationalize the work. Okay, and so how are we doing and where are we going? We have now, as we've aimed, we've transitioned from recommendations to implementation. The implementation team has been pulled together. And that includes many of the executive leads from the task force. We have identified leaders for each of the 11 strategies, as I just noted. The strategy working group are under development. And then those groups will be responsible for specific project plans and then timelines for interventions to be done and activities to be done over the course of time, and the reporting up to the Executive Diversity Leadership Board will happen over time. And that next meeting, they'll be meeting later in the fall just to talk about design, and then beginning in 2022, the reporting of the work out to them will begin to happen. The shared measurement system process is happening already. FSG is already in place. We are meeting with them. They will be onboarding the members of the working groups to the strategies so that happens in a coherent, consistent way. We grow into the work as a community. We become a little bit more comfortable together. The conversation is critical. So thank you again for today. As a team, as a community, and then how we use the data to learn, how we reflect over time. We do that together. And then, of course, the implementation of the full measurement system will begin in early 2020. And I apologize for the background noise. I actually live in Manhattan, and near Mount Sinai, and so I can't say that those are your ambulances in the background, but they may be. So my apologies, nevertheless. And then the other important stream of work relates to communication. So, the communications team, David Feinberg's group, and some consultants have been key to ensuring that we are sharing information in a transparent way and in a way that is understandable by all of us. And so the roadmap document was published. It is online. Please find it if you have it. And then the announcement of the work itself happened back in April. And then we have an ongoing process to continue to build awareness of how we're doing. And then an opportunity for engaging staff at large and getting some feedback about how we're doing and what else we need to be, what we may need to be doing differently. Right? An important conversation back in May was the conversation around the roadmap. And that was quite robust, as one could appreciate. There's never enough time for this, but there continue to be ongoing conversations, including this one, that are critical so that everybody understands what we're trying to do, that we get it right, and we have the full engagement of all of our Mount Sinai community to move forward. And so again, back to the website, there are, in addition to the articulation of the roadmap itself in a easy to appreciate an understandable way. Here's the link, by the way. There's a toolkit, and if you haven't accessed some of the information in there, that please do so, and there may be something in there that could be helpful to your task force. And then, in addition, we are putting out now, we've begun to put out a weekly bulletin that will allow us to focus on a particular issue or two that relates to the work of the roadmap. Interestingly, no, that's not me, that's Sean Lee and Angela Diaz, who many of you, hopefully know, and if you don't know Angela, she was my intern back in the olden days, at least we thought they were at the time. And she is in charge of adolescent medicine for Mount Sinai now for probably at least 3+ decades. And so Sean and Angela have agreed to be the voices to communicate out the progress, and so that in an attempt for us to be to share information from several different levels, and hopefully that will help and with people tuning in. So all that said, that's where we are, where we're going, a little bit about where we're going. Good progress is happening regularly, and so just if one would ask the question, well, are we serious? Is anything happening? What's different today than yesterday? My response would be, well, we can begin to articulate some real progress with new happenings and perhaps even at times, some measurable, some data that for which we can from which we can measure progress. More importantly is, how we feel that we are compared to where we were, if you have a chance to reflect back 6 months ago, a year ago, 2 years ago. So hopefully this conversation has given this quick update, has given you a chance to appreciate that indeed we are serious about this. We have a high level of commitment. This is not about business as usual. And more importantly, the question is, where do we go next with this? Where do you go? How do you engage in ways that can help accelerate the work? So real quickly, Chats for Change, if you're not familiar with that, that is an ongoing opportunity for a dialogue around an important issue in addressing racism and bias. That program now is national. It is being replicated, pushed out, and so that other medical schools will begin, and systems will begin to have focused conversations, and then from those conversations, advance work in a very important way with anti-racism in mind. While addressing bias and inequities are important, addressing racism is different. There's a new system that was just launched, the Center for Anti-Racism in Practice. Neil Nahas and Angela Angel Palermo lead that effort. And that will probably become the most important learning center for us in this space. And you all will have access to those experts as well. Angel Palermo, if you recall, well, Angel Palermo, I didn't speak to her yet, is the lead for strategy, I think it's strategy 11, the 10 or 11, that relates to becoming, advancing our learning in anti-racism. So this will be a very important resource as the center comes together fully and robustly and supporting the roadmap strategy and all of us. The Committee to Address Anti-Asian Bias and Racism is a relatively new committee that the Dean Charney, launched a number of months ago. Intersecting with the work of that committee will be critical to ensure that no one is left out, no issues are left out, and we're working together on these tough issues and not either ignoring them or perceived to be ignoring them, right? And by the way, I sit and several of the members of the task force actually are participants in that committee. So Jim Tsai, again, high level, who's the president of Mount Sinai, New York Ioneer, Mount Sinai New York Ioneer, and Amanda Ree, who's in leadership operations, are the co-chairs for that committee. And then there are a variety of others that are new committees or initiatives that have begun. This is a short list among many that I just sort of pulled from for the purpose of today. And many of you have heard about the new Laureates program that Eric Nestler launched on behalf of Dr. Charney. They already have either 2 or 3 new recruits, people of color. I think all 3 are Black scientists who have been recruited to Mount Sinai over the past number of months. Why is that new? Well, that will give us about a 300% increase from what our baseline has been. That has been a heavy challenge for Mount Sinai and other research institutions, okay? So this gives you a sense of where we are. So anyway, that's a little bit about the task force. I hope that you can, in the roadmap and where we're going, what I hope to do is a few things today. Lay that out in front of you so that we now understand the task force, the product of the task force, the roadmap, the relevancy of it. And then more importantly, I'd love to hear from you where there are or might be areas of intersection that this work becomes stronger, can be realized and appreciated sooner, and can be of relevance and value to you as individuals and as members of your department, and for you all as members of our Mount Sinai community. So let me stop there. As I promised, I did want to keep a good chunk of time to have a conversation with you all. So maybe I'll stop the share now, if that's okay, and then we can open up to some questions that might be on your minds and your thoughts for me and or for me to take back to our planning and implementation team. Thank you.
Thank you. Thank you for that, Dr. Butts. It's a pretty comprehensive eagle's eye view of what's happening across the institution. It's comprehensive and at the same time, a little daunting and challenging. The degree of detail that is entailed here is designed to permeate across the entire organization. But for a smaller group of people, such as the Institute of Critical Care, what are some of the areas that we should focus on?
Yeah, I would say there are at least 3 or 4 that regularly come to mind we think about clinical departments, right? One is care delivery, right? And what does that look like? Is there unevenness or not? How do you know? How do people, patients in particular, and your staff think about the care, equity of care, access to care, outcomes of care, right? And that's a pretty heavy set of issues, right? And I think and by the way, that's strategy 2. It's not unique to Mount Sinai. That is the challenge of healthcare, right? And particularly in the United States, right? And it's not as though we've done anything wrong. However, we are participants in a system that has, when you look at it and the impact of it and the output of it has been uneven, and some would say segregated. Others would say, would use other terms.
Access to care.
And access at least, right? And so I think, that's one. The other, and everybody can play a role in addressing better participation in the spaces of clinical care and research. And so, as I look at, this group, wow, right? I mean, I just looking at the names without even seeing the face, you've done a pretty good job, it seems, all right, with participation of people of color and among others, right? And so but then the question is, can you do better? How much better can you do? And then what about inclusion and what about leadership, right? Those are typically still questions or challenges for most departments, not just clinical departments. The other is becoming better learned in the space of equity and disparity, but even more so anti-racism, right? So those are 3 very important strategy areas for which I think understanding them better and connecting some dots with what we have available or beginning to work more directly on, and interests in and possibilities with this department. That's just, to me, those are relatively low-hanging possibilities, and of course there are many others.
Yolande. Hi, Dr. Buss. Thank you very much for this really incredible talk. As we sort of think about this, one thing that I sort of want to think about is, the majority of us sort of are really clinically oriented people. And so as we sort of get started on this work and want to make sure that we can both advance the larger work of, your area and the roadmap and the strategies, and really examine how ICCM is aligning with your work and advancing, I want to ask about ways to avoid sort of pitfalls as people who are new to this work, to make sure that we are sort of better learning the ways to actually address this and make sure that we are actually advancing ourselves and approaching and learning in a way that will be beneficial, as opposed to sort of trying to tackle this large project without necessarily being armed with all the appropriate tools, because it's not sort of the background that we all come from.
Yeah, I think, listen, you're touching upon, the ultimate organizational challenge, but also, the bigger challenge is, becoming comfortable even with beginning the conversation. And I think that, at least my experience is that, we're at different places with that. There are assumptions that are made, and people often look to me as the expert in this space because I'm a Black male. Yeah, we as Black men have had a particularly interesting, I'll say, time in America, right? I'll just leave it at that. But doesn't make us the experts in addressing these issues. We are certainly bringing a perspective that is important. And then for those of us who've had the opportunity to reflect, think, do even more in this space, we then become more experienced in it. But the conversation, the dialogue, needs to include many more others. And in fact, just like with good innovation work, the more different the folk who come in with the experiences, while challenging, right, it makes for a more positions a group to be even more effective once the conversation can begin and go in the right direction, and lining up priorities for the department, one, and then hopefully in alignment with what's happening around the department. That takes time, it takes thoughtfulness, it takes connectedness, et cetera, right? And that's gonna look a little different from every department. One of the reasons I really appreciate the opportunity to talk today is so that you know what's happening around you. Because we're getting called all the time. Hey, can we do this? Can we have support for that? Well, let's at least understand what's out here, where we're aiming, what the North Star is, what your contribution can be based on what you're already doing first. And then let's think about the synchronization and so on. More importantly, back to the point to be made is that we can elevate and help maintain and maybe even broaden the conversations that absolutely need to happen, right? And I think that if probably the biggest challenge early on, which is hasn't gone away, is the becoming comfortable being uncomfortable, right? And most of the leadership would agree that the job for people who do this, and including me, and I don't want to start just about me, it's probably the toughest work for systems like Mount Sinai, right? I'm glad that people can appreciate that now, after how long? I've been in this space for, I've been at Mount Sinai for 4 decades and in this space for 2 and change, right? Well, I've realized that a long time ago. The other is that you don't see, and this is just another part of my response to your question, you have to level set and then get your benchmarks right. Achieving what we are aiming to do will not happen overnight, right? Will not happen overnight. But one. Number 2, the sense of urgency in getting there will be different among us, right? And so the value of having medical students who have a very different sense of urgency than faculty, right? We've gone through it and we got through it, well, okay, you'll get through. No, that's an inadequate response, right? So, but having the opportunity to have that kind of a conversation is so important, as is having perspective from people who don't look like us, right? So of everything, I think taking advantage of leveraging the relative diversity amongst you, and including people who are newer to the table, to the tent, just positions you to be, as you begin to address in a fairly inclusive way, that much more powerful, that much more positioned for success over time. That's a long-winded way of answering your question. I took the opportunity to put a little bit more perspective in it. So I thank you for that, Yolan.
Thank you very much.
Hopefully I at least answered your question.
Thank you.
Definitely, thank you.
Somewhere in there is an answer. Ilsa, what I'm doing now is one by one introducing you to the members of the task force, Dr. Butts. Ilsa.
Hi, thank you very much for your talk. I'm one of the new intensivists, and it's really an honor to be part of this group and carrying this conversation. I think it's very important that we create this type of environment and we continue to further this important topic.
Jade. Sam or George, any comments or questions?
Yeah, hi, Dr. Butts. This is Sam Aqua. And again, thanks a lot for speaking with us. And again, I want to congratulate your team, at least bringing, awareness to the whole issue, because as you know, I think knowing where we are, knowing the issues, and being able to talk about it as we're talking right now, goes a long way in trying to identify ways to how to improve, right? And we working, as a group, with the ICCM, trying to, see how we can, educate more and bring awareness to all the disparities. I think we work in a clinical space and we do this on a daily basis, so sometimes we don't recognize what is going around us, and at least bringing that, recognition, I think will help us, understand more the disparities and and how to improve. And I guess piggybacking on Yolan's question is, it's a very big and broad topic, you know, and the question is, with all these years, you know, what have you found to be the most effective, you know, in the clinical space? You know, I mean, what, changes, you know, can we make, you know, to at least effect immediate change? And if you can also give us, you know, maybe some thoughts of, you know, how we can measure also, because, you know, again, a lot of it has to do with education, you know, and the question is, you know, which education is effective, you know, and is there a way to measure it? You know, I like to, you know your thoughts on that.
Yeah, I think, you know, good to see you, Sam. You know, you asked me some of the toughest questions. If the answers were easy, hey, right, we'd be well on our way. They're not. I think probably the first part of getting you know, to your answer is looking around and trying to understand, you know, to what degree an event might reflect something much deeper, right? And so you wake up and there's a pattern that reflects an event that reflects a pattern that's inconsistent with what your institute, you know, stands for, and Mount Sinai stands for. You know, not everybody has access to the same things, high tech, for example. We've seen that when Lynn Richardson studied that in the emergency room. That was clear. It's the same thing that some of the more nationally published literature were showing was coming up, right? Whether it was by insurance status or something else, it was happening. There was a pattern there. And so, you know, that's one. The other is, you know, we often hear from, you know, students who are less shy to talk about it amongst themselves, for sure, more shy to talk about or ask about it and make a deal about it when they're being supervised. But it's clear that, clearer and clearer, and I, you know, don't know what this looks like for you, if at all, that the level of supervision of care is not always the same, depending on insurance type and so on. But those are things that are, right, that don't require necessary money to do anything about, but somebody to document in some, you know, reasonable, you know, way for which you can get your arms around and not, you know, splash about it. But those are, you know, as it relates to, you know, care delivery, there are some things that we can at least do to better understand what's happening around us and whether they're consistent or not. Then becomes, you know, to what degree do those things, if they exist, reflect policy differences or not? Some of them not about policies, the way in which we've learned to behave, behaviors that we have found acceptable by ignoring them or not, right? Et cetera, et cetera, et cetera. So that's the, you know, the clinical space, I think, you know, is ripe for understanding whether we're doing our best. Things are uneven or not. And if we're not sure, well, then, you know, let's go a little bit deeper and so on. Related to that is, you know, concordance. Concordance makes a difference. You got a great mix from what I could see here, you know, and so hopefully you're in a better position when there's a clearer need, you know, for language concordance, you know, to make the difference. Quick example, you know, I have a mentee who's now a fifth-year ENT resident. You know, I called upon them when a Latinx parent of a friend, you know, needed to be seen sooner than later. He made himself available. And guess what? Her response was, she was so grateful, not for the care was one thing, even more so that he spoke Spanish. He understood her, right? And it was, for ENT, it was the first time ever in her many years of, you know, going for care where that happened, right? So, you know, I think those are taking advantage of the relative riches and the diversity that you've got more intentionally, because it matters more than sometimes we give credit to, and right. And then the other is, you know, trying to better understand if indeed, you know, care can be better and more even around us. And those are things. And then of course the third is back to learning, and we learn together, grow together. You know, and some maybe you already have this on your horizon, or doing it or have your horizon. You know, reading some of the, you know, more relevant, you know, literature, and so that, you know, there's good learning, reflection, and conversation. By the way, Sam, to that point, there's some religion that I still find difficult to read, right? And I force myself because it's so painful. Our history has been so painful, and then to read about it, there's some language that can be very painful, right? And I have to force myself to. And you start there, and that's more than enough. And it's tough. And get help. We're here to be helpful and doing this together. Finally, Sam, you know this. That's that thing that we have to be the experts. You have to know that your department has to be the experts, and that's part of the. That's an important reality to come to grips with as well. We can do this together. We have to do this together if it's going to be done at all, and if it's going to be done right.
Thanks.
Thank you. Cheyenne?
Yes. Hi.
Do you have a question or comment?
No, I think this was very informative, and I really did enjoy this presentation. So thank you for all your time.
Thank you. Dr. Butts, I'm going to ask a little provocative question. We are fortunate to be in the Northeast with significantly more diverse population than other parts of the country. And I have friends in other parts of the country where when I discuss these topics, they talk about academic activism, stay in your lane, all these kinds of things. Have you ever encountered something like this? And how does one handle it?
I think for far too long, first of all, we're always made to feel we have to stay in our lane, right? People of color, those of us in academic medicine, those of us in cervical, that's right. That's now, I would say, no, so that's not an unusual expectation, right? I think what I've tried to do, and this looks different every year, is leverage opportunity for a conversation. So there's an opportunity now for a conversation, right? To become a good listener. I told the chair of psychiatry a little while ago, I was supposed to go into psychiatry, and I made a mistake and did my psychiatry elective in the middle of the winter at the medical school I was at. Well, that didn't work, right? But you don't have to be a psychiatrist to become to be a good doctor. You have to be a good listener. And I would, listen, hear people out, and then look for an opportunity to, if they're at a point where they've softened their view a little bit, to have that dialogue, right? And then get to the point where, if not now, then when, right? If with all of what we're seeing and all what the evidence suggests, and by the way, we're not calling any one of us racist. However, we live in a society and we've been working in institutions that can and need to be better. And let's talk about, what some of the things are that need to be addressed. And if not now, then when, right? And so this is the opportunity, and that's why this is the opportunity while people are still focusing on it, even if a little bit, to do it. And I think that it's easy, the quick response is, medicine is so pure and good, and because we're good and kind and all that, but man, we have not had a great history, right? So it may be that a little bit of reading, sharing some literature, if and when the person is ready for it, right? And so as an institution, we've not always been as ready as we are now, right? And that's why this is our time, okay? And so meeting people where they are is critical, right? If and for some, it may not be, maybe it's in a couple of years, but hey, here's a little something you may want to take a look at. Here's some data that may be, and then let's talk some more. Right? Keep the conversation going.
Yeah. Okay.
Yeah, Umesh, just a comment to your point. Again, the question is, stay in your lane versus, the lane which has been created for you. Yeah. So I think that's where, encouraging representation, for us, we just feel we are in a space where it wasn't created, we had to, forge our way through, So again, it's just opportunities you have. And that's how I'll answer that.
Yeah. So Sam, I completely agree with you. And, we are, like I said, fortunate to be in an area that is, you see, politically more diverse and accepting and all this. But and I'm sure you guys have been in different parts of the country, and there is that subliminal hostility or whatever. But of course, I think that this is a society in change, in turmoil, and hopefully all of this will lead to a better, newer day, a morn, a brighter morn.
Hopefully, but you're right. We gotta allow for the conversation, right?
Yeah.
Because I think
Yeah.
I can't. Some of the things we're seeing, hearing around this, vaccine hesitancy is
it's all
irrational. To me, it's irrational, right?
Yeah.
But I want to let me understand why people are thinking that way and saying that.
Like you said,
maybe,
you want to meet people where where they are. Meet them there and see if you can lead them somewhere. I don't know. George, do you have any closing comments?
Yeah, Dr. Butts, thank you for this great talk and insight into the programs. And for me, I think that, we've done a lot in now speaking about it and, creating the forum for people to open up and talk about it. But I still think that there's ways ahead to go because there's still some discomfort in talking about it. And that seems to persist. And especially in our system where we work in a multidisciplinary environment. Now we sit here as physicians and talk about it. We talk about it in silos, but the problem is a cross-disciplinary problem and the solution has to be cross-disciplinary. So how do we get from where we are to the true next step? Yeah. Being really open and comfortable talking about it and deriving the things to do. It's, now we're talk for change, but then when is the do for change? How do we go from where we are to the next step?
So, so it depends on where you are. Your department institute better than I do, right? So you have to figure that out. You have to see how do you square, even recommendations with the reality. That's your question, right? And I think, that's why a task force, departmental level committee or task force becomes critical because you have to figure that out, right? Both in timing and, depth and breadth. I think, and it begins, my last comment or so, then we'll start, is the, if leadership is behind you, it's a little easier to have the conversation and to know that, what comes out of the task force, can be embraced.
Right.
Yeah, I suspect we continue to have these conversations because this is an incremental process. This is not a process that's binary and is going to change overnight, but already we made so much progress. It's fantastic. Thank you so much, Dr. Butts. We, all of us from the Institute are very thankful. You have set the tone for the coming year for our Institute, and Yolande and his team, the task force that we have created, will continue to search for these answers. But I think you've given us some pointers where as clinicians and maybe even as clinical researchers, where we focus on care delivery, equity during that, and care access as well as outcomes. That's one side. And then of course the staff and our interactions with staff and mutual respect and really a lot of the unconscious or subconscious biases that become apparent once you learn to recognize them. All of these are areas, are target areas for us. And hopefully we will come up with an abbreviated but comprehensive plan to see how within our clinical institute we can continue the mission of Mount Sinai.
Well, thank you for that. Again, thank you for the opportunity. The last thing I will say is that some, and I You'll see it soon from yet another department, I won't say who, where they're also working on fine-tuning a statement, an affirmation statement that they're going to post and share. And some departments have done that. So that helps to anchor their North Star, right? And then there you go, right? Rather than people suggest you're splashing around, you don't have a North Star or you're not serious. Well, here it is, right? And then your task force or committee can begin to work out the priorities at a given point in time. And we will always be here. I will personally, my team and others, to support all of that and all of you. And the other point you make, I think, while I've talked about patient care, how we treat each other is just as important. And so thank you for bringing that up, because we sometimes can be better in that space as well.
Okay, thank you, ladies and gentlemen, for attending this very important discussion.
Thank you all for having me. Appreciate it.
Okay.
Thank you.
Bye now.
Thank you.